factors affecting growth and development of the airway, and the role of the dentist in pediatric sleep-breathing disorders. Here's the story. Again, I want to repeat, but when you treat an adult and you put a Moses, albeit the finest appliance known to mankind, you're putting a crutch under them. And they're going to have that crutch for the rest of their life every time they sleep. When you treat a child, you're intercepting the problem, you're curing the problem, you're eliminating the problem for the rest of their life. They're not going to need this because they have the airway. And so this is really where the action should be. Every case that you see in your office is a failed pediatric diagnosis and treatment. That's the way I see it. And this treatment of children is probably the most fun. Now, I realize you don't all see children. That's too bad. I don't either. And so every time I get one of these practically, it's like a case study because they come from Children's Memorial, and they're always a special needs kid now, or there's something very special about them. And it's absolutely rewarding. It's absolutely sensational. And so I want to share with you what I do. A, because it's so simple. And you know this stuff. You're going to go, oh, why didn't I do this before? It's that simple, and it's that much fun. Dental malocclusion, narrow adenoid facies, large tonsils, chronic allergies have been implicated in respiratory obstruction, mouth breathing, and sleep-disordered breathing in kids. My objective is to explain how these things happen, how to recognize them, how proper treatment in kids involves interception and curing of the problem, and it's a multidisciplinary approach. The term kids is defined as the period from embryo to adolescence. The embryo starts here, and then right about here, 60 days, the embryo is termed a fetus, and the fetus becomes an infant at birth. When do you start treatment? In utero, exactly. Thank you. You start right here. Because this is when things happen. Thank you. That's exactly the answer. What? You want to start before this?
We were just talking about those environmental issues you were talking about before, which they maybe you just give the mother a Moses supply.
Actually, that's very interesting. You're way ahead of yourself, because what we were talking about here that I didn't, yeah, I know, another hat. What we're talking about is what I have. This one says apnea, but what I'm working on is, because this is so important, pregnant women in the second and third trimesters actually get snoring, apnea. The problem is toxic high blood pressure called eclampsia, and they deliver lower birth weight kids. They deliver more retarded kids. They have premature births more, and they have difficult deliveries more. And so you're absolutely right. And so what we came up with was a design so that it'll be ultimately a one-size-fits-all, because pregnancy is a temporary condition. And so then they gain enough weight to create this. So this one says apneator because that's also the truck driver model, but the truck driver's got 6 sizes fit all. This is going to be the, when it goes, it'll say pregnancies instead of apneator, but yeah, it's in my pocket and ready to go. And you're absolutely right, and I'll have to put that into my slides. Thank you. This is what it's about. We want to pass these around. There's only one in there. We might want to hold it together. Okay, well, you want to give the rest of this lecture with? Okay. All right. I mean, you know this stuff better than I do, I think, so it's very important. Okay. So the head and neck are formed by, this is the part you forgot, so I have to go over this myself here. The head and neck are formed by pharyngeal or brachial arches. In humans, there are 5 pairs. Now get this, 1, 2, 3, 4, and 6. Like, who the hell didn't know how to count? I don't understand, but you watch, and the slides all say that. And I thought, well, this must be a typo, but every book I go to is 1, 3, 4, and 6. Okay. That's how the academics keep control. They just do things you can't explain, that's all. Okay, so we have a picture. We have the stomadeum and the pericardium, and we've all seen this picture. And it's interesting because this picture, you don't know if it's going to be a chicken, a reptile, or a human. And so it all looks the same down here, doesn't it? And so we have some anatomy. We have the eyes forming here. We have the mouth forming here. And then you see all the parts, except we don't recognize all the parts yet. But it's interesting because, yes, look at that early stage. This could be days old, and all of a sudden we're talking pharynx. There it is. And so then here we go. 1, 2, 3, 4, and 6. Go explain that one. But anyway, so you see where they form. And the interesting thing is this is our area of concern here. This is where we're going to get oral pharynx. And the interesting thing, because it comes from these 4 branchial arches, we have a complexity of nerves. So I was saying when I did the anatomy, certain tissues, like you have, are innervated by 7, 8, 9, 10. You have all these nerves innervating, this multiple innervations of the same organ and the same body part. And so it gets, the neurology of all this gets complicated. Each arch contains its own artery, cranial nerve, muscle component, and cartilage bar or skeletal element. And so there's briefly, the slides in there for your reference, but at roughly day 44, the genioglossus, the tongue, starts to form, and then at day 6, the embryo is then termed a fetus. And if you look on the right here, you get an idea of, in the various arches, tensor tympani, we're talking 5th and 7th, and we're talking 12th nerve, and the stylohyoid, we're talking 7th nerve, and stylopharyngeus, we're talking 9th nerve, 10th nerve, but then all of a sudden we have sensory. We're looking at trigeminal cord of tympani, we're looking at sensory, we're looking at lingual, the lingual division, the 3rd division of the trigeminal. So, interesting structure, very complex structure. And so this is really cool. There's a lovely textbook, and you see what's starting to develop, and you see the central nervous system, and then, okay, pharynx right in here. And you can watch and see it develop as it goes. Cardiac, heart. And so as it goes on, they take this apart at various points to emphasize certain things. And so you're looking at pharynx here, early mouth here, and then you see pharynx relative to the forebrain and the central nervous system here. And then you see the way this thing forms. And now we're looking at oral pharynx, and again we're looking at the branchial, the pouches, and so you see a little more intimately related to the nervous system. And it goes on. And now we see, anyone want to say what that is? Okay. Trigeminal ganglion. How about that? Semicircular canals of the ears. Doesn't look familiar yet, does it? And right there, the white structure. Hyoid bone. We've been talking about this for 2 days now. How cool is it to see it when it's 24 days old? Okay, red dot. Meckel's cartilage. And oropharynx. And nasopharynx. And nasal capsular cartilage. So we're starting to see the septum. And then the tongue appears at approximately 6 weeks. It develops some swellings in the first 4 branchial arches. So you can imagine how complex the innervation is. So you got 5th nerve, 7th nerve, you got 9th nerve, you got 10th nerve, and 12th nerve. This is heavy duty stuff. Okay, and so we see it here. And when you look at this, there's the tongue, the first arch, and okay, and this is what it looks like when Frank Netter draws it at 6 to 7 weeks. And there, actually, there's the tongue. Netter, I think, was into blue oral structures for a while period. That's Netter's blue period. And so we see the pictures like this, and then we look at this here, 37-day-old embryo, and look at, there's the mandible, there's the maxilla, hasn't even come together in the midline yet, and so it's very interesting to see stomodium. Okay. But it's interesting, as I was saying, you know, in school, if you wanted to pass every test, you had to know ontogeny, recapitulates phylogeny, and so you're like, what is that? And really, it's interesting because, as I said, you couldn't tell the difference between a frog and a human at that point that I showed it to you. And so at this stage of the embryo, the rat is indistinguishable from the human except by DNA testing. And then Jacquetta Hawk says that starting from a single cell, I passed one period of my life with gill slits inherited from my fishy ancestry, and then for a few weeks sported a tail. It was hard to distinguish from an unborn tree shrew. Why think of viruses or Precambrian organisms when inside this delicate membrane of my skin, this outline of an individual, I carry the whole history of life? And in 3 words, that says ontogeny recapitulates phylogeny. So, okay, and so the tongue develops. And then the infant starts here. And so recapitulating, very instant replay here. You start with the genes, you wind up with the kid. The entire tongue is within the mouth at birth. Now this is interesting. The tongue doubles in length, breadth, and thickness between birth and adolescence. And during that time, it should stay entirely within the mouth. Guess what? It's our job to make sure it does stay in the mouth. That's the charge. How can we do that? That's what we're talking about today. Growth of the pharyngeal airway consists of a balance of all the separate growing components. So we have to deal in, we're dentists, look what we're dealing with. Brain, cranium, airway, nose, tongue, and mouth. They're all interrelated. Alterations in function cause changes in genomic expression. That's called epigenetics. The tongue and the pattern of swallowing influence the path of eruptions of the teeth. So far, telling you nothing new, right? Tonsillar growth is variable. Tonsillar growth can't be considered true growth. Tonsillar growth, the size of the tonsils reflects their immunodefensive competence rather than the age of the organ or the age of the child. Epigenetics, the study of heritable changes in phenotype or appearance or gene expression are caused by mechanisms other than changes in the underlying DNA sequence. And so processes that act on DNA and modify the expression of genes without modifying the genetic code. So I'll show you a picture again of the 2 twins, but the fact is that these 2 twins had they were identical twins. They had the same genotype, but obviously had different phenotypes. The phenotypes can change based on the factors of function affecting them. This kid had to open his mouth. The kid you saw on the left before had to open his mouth to breathe and change the whole appearance of his face. And the only reason you know it changed is because you saw the twin next that breathed through the nose. When we see these kids, these are abnormal things. These are the 2 things. And so I'll tell you, this is sort of when you give a lecture like this, everybody says, where do you find these slides? And so really, you know what you want to say sometimes, you can't find the right slides to demonstrate it. And I was really quite frustrated. So ultimately, I went back to my high school yearbook and I found these pictures. So it's interesting. Alterations in function cause changes in genomic expression. Dental intervention in functional problems brings about epigenetic changes that alter genomic expression and are inheritable. So this is very powerful stuff. It is inheritable. And so the question we have to ask, if we could see the kids of those 2 classmates of mine, I wonder if the one kid on the left would have had the long face and mouth breathing, and the other one would have had, been handsome and closed mouth nose breather. We don't know. But this is the kind of stuff that is being studied today. Speech, important characteristic that distinguishes humans from lower animals. So we talked about the flexible, compliant airway being a requisite of speech, and we said that in humans and lower animals, swallowing and breathing can occur together. And this is a very nice protective reflex, because if you visualize that somewhere in Africa today, there's a zebra, and the zebra is taking a drink of water at the pond, and that if there's a tiger trying to eat the zebra for lunch, because the zebra can breathe and swallow at the same time, he will presumably, if the wind is in the right direction, smell that tiger coming and get out of there. And so that's why it's such a protective mechanism. And so in children, interestingly enough, children are different. They breathe differently, and they swallow differently. And the children have what we termed earlier the locked epiglottis. The epiglottis is actually interlocked, overlaps the uvula, and so we have a continuum where it's like a shield. That's called the locked. The epiglottis is behind an approximation to the uvula, and so the reason we have that again is so that the child can take air in through the nose and breathe, and he needs to be attached, so we need suction at the lips to attach, but we need the fluid to go down into the throat without choking him. So that's how this mechanism looks from the side, and it's protecting the airway. It's protecting the airway by creating a shunt. Okay, and so we saw this picture, and this is a child, and the attachment is to the breast, and we said that children have flat faces at birth, and that's why the breasts are so beautifully shaped. And so then they're making a big deal out of breastfeeding today, and look at the cover of Time magazine just a couple of months ago. And so the point is that these two here were sanctioned for improper display in a military uniform. So breastfeeding is still not universally accepted. And so, interesting. Between 6 months and 2 years, the uvula ascends, the epiglottis descends. The back of the throat and soft palate become the compliant parts of the adult human airway. The posterior tongue descends into the pharynx totally by the age of 4 years. So, the point is, the brains on children, we said, are 3.5 times larger than other animals, and the brains yet are still as smart and functional as they are. No child is ever born being able to articulate speech. But there's a better reason. The child can't articulate speech because they don't have a flexible, compliant airway. It sure makes a lot of noise when they cry, but they can't articulate speech because of the locked epiglottis arrangement. They don't have a compliant airway. They can make the sounds, but they can't articulate them at will, the vowel sounds which come from the oropharynx. The tongue musculature, tongue function, and breathing influence the development of the face and the eruption pattern of the teeth. Okay, so in the adult human, the anterior 2/3 of the tongue lies horizontally in the mouth, innervated by the 12th nerve. The posterior third of the tongue lies vertically and forms the anterior wall of the pharynx, and it's innervated by the 9th cranial nerve, or the glossopharyngeal. So the tongue origin is in the first 4 pharyngeal arches, and the nerves involved are 5th, 7th, 10th, and we got 12 too there. Hypoglossal. Okay, and so there's what we see. In this picture here, we see that the epiglottis has descended to some extent. The uvula has ascended. And in this is our field of interest for this weekend. We're talking about the flexible human airway. And when we look at this from the side, we see a different picture. And as I said, the whole area of concern is from here to here. We're looking at an area about 1.5 inches long. And all is concern for 3 days, and all this concern is occupying dentistry and medicine in terms of sleep medicine, 1.5 inch area in the throat. So, with the locked epiglottis, can infants and children have obstructive sleep apnea? You have this epiglottis behind the soft palate, and the tongue is in front of it all, and the epiglottis is rigid. So can kids have apnea? Yes, of course they can. But the mechanism is different. So if you have apnea and you go to bed and several of you had apneic episodes last night, despite wearing the noses, the fact is it was the tongue collapsing on the airway and a combination of negative pressure. That's a different mechanism. So in children, it's obstruction. And the obstruction, the subjects that can obstruct would be primarily, number one, we have to concern ourselves with enlarged tonsils and adenoids. And then we have kids are born with narrow upper airways. There are kids who have particular children specifically who have macroglossia, such as children who have Down syndrome. And there are children with micrognathia, such as Pierre-Robin and Treacher-Collins syndrome. And then children have restricted nasal airways for various reasons, which could be and again, they're not born with allergies, but they develop early enough. And that's one thing that can happen. Okay, so these kids are nose breathers. They're sleeping with their mouths closed. Their tongue is in the roof of the mouth, facilitating normal growth of the palate, broad dental arches, straight teeth, and beautiful smiles. And these kids, in contrast, are sleeping with their mouths open. Their nasal breathing is obstructed. These kids are mouth breathers. Their tongue is in the floor of their mouth. This will affect their facial development and the position of their developing teeth. If you look at these kids carefully, you can see spaces here. You look here, you already see the tongue sticking in there. There's the tongue sticking in there. And these kids, look at the lips on this kid. They're giant chapped lips. And so this is our concern. We got to get these kids closing their mouths. What do we have to do? How do we do this? Obstructive sleep apnea in children is a serious problem. Children, as I said, are different than adults. So an adult, we don't act out. We say, hey, I'm really tired. But ADHD, attention deficit hyperactivity disorder, this is a comorbid consequence. Enuresis, child over 4 wets the bed. That's the kid. Over 4 wets the bed and snores, 90% chance, over 90% chance that they have sleep apnea. 2 little clues like that. Ask the questions. Failure to thrive. Now, this is interesting because there's a little genetics involved here, but sometimes these kids, you'll see them skinny as a rail. You can see all the bones in their ribs. And that's failure to thrive. And they don't eat. And then same problem, you'll see these kids that are hugely obese with apnea as well. Morbid obesity. And these kids sometimes are so big they can't even breathe anymore. And then we have cognitive disorders. And we have behavioral disorders. We have disrupted sleep. Cardiovascular problems. Cardiovascular problems in children. How sad is that? And yet, Rick is showing you that it's happening. Hypertension in children. It's awful to think that there's kids walking around with blood pressures, like 140 over 100, 160 over 100. Then we have hypotrophic faces and jaws. And then we have delayed, and we talked about the hypotrophic faces and jaws. Sometimes you give a kid a pacifier and they suck their face in. And then we have delayed development of motor skills. And we have executive dysfunction. Executive dysfunction in a baby, how does that happen? Well, you have a 4-year-old kid and you say, listen, go upstairs, get undressed, make your bed, and get in there, go to sleep, turn out the light. Kid can't remember by the time he gets upstairs what he's going there for. That's executive dysfunction. They can't do consecutive tasks. And these are just some of the comorbid symptoms of obstructive sleep apnea in children. Children with obstructive sleep apnea generate 2.6 times the amount of healthcare expenses as non-obstructive sleep apnea patients. Now right there, read OSA children. Think sleep disordered breathing children, because it's the same thing. When the pediatrician, the sleep pediatrician, when they talk about these kids, it's sleep disordered breathing. If the kid's got upper airway resistance, to them it's just as serious. And they're as concerned about the upper airway resistance as they are the obstructive sleep apnea. And because of that concern, that's a reason why they're so concerned about the carbon dioxide. Because the carbon dioxide changes, fluctuations, they can pick up faster than the oxygen. The airway collapses during an apnea episode in sleep. Children who have obstructive sleep apnea, read sleep disordered breathing, have smaller and more obstructed airways than non-obstructive sleep apnea children. The structural and functional problems created by airway obstructions during sleep result in intermittent hypoxias and hypocarboxias in children. I need to change that. Glory, make note to change that one. It's not hyper. Okay, thanks. Obstructive sleep apnea, however, only occurs during sleep. That's the problem. The problem is these kids got to breathe through that same airway during the day, and it's smaller. So what can we do to help these kids? We can make the airway bigger. Nice, nice. Why don't we do that? We're going to learn how in a minute. And same anatomic conditions exist during the day. They affect growth, posture, oral facial structure, and function, neurological and cardiovascular function, learning ability, and behavior. Oh my God, look at all the things we have control over. Look where we can take this. Look how much satisfaction we should be getting out of solving these kinds of problems. So, look at the literature. Again, possibly one of the fathers, one of the icons of sleep medicine, Christian Guilleminault at Stanford. He probably, with Bill Dement, organized the whole field. Guilleminault is, if you want to know one name, it could be Guilleminault in this. It's published literally thousands of papers. So the point of this article, published in Seminars in Pediatric Neurology, 2001, says that upper airway resistance syndrome is more, today they don't call it, changed the name, big deal, but they made a big deal out of this. It's upper airway resistance, not upper airway resistance syndrome. So I think if you see UARS and UAR, you could interchange them if you want, but technically today it's UAR. Anyway, upper airway resistance is more common in kids than obstructive sleep apnea. That's what I've been saying. Flow limitation can be measured with nasal prongs. That's the good news, because that's what we have. That's what you put in a metabite. Metabite doesn't come with. If you ask Rick, I think maybe he would include pediatric belts if you get a metabite, especially if you get it today. He'll be very happy to do that, I'm thinking. If he isn't, I'll talk to him. Mild craniofacial developmental anomaly is often seen in kids with upper airway resistance, and examination to assess the need for orthodontics is the subject of our lecture today. The need, you see it. Okay, and so here's another article, Guilleminault again, and he's saying, today most of the patients with upper airway resistance remain undiagnosed and are left untreated. Isn't that a shame? Today we're discussing the diagnostic factors found on an examination that suggest conservative treatment and or prevention. And I use the word cure also. Upper airway resistance may lead to clinical symptoms without complete apnea. That's the point. I said that before. There are patients who suffer as much with upper airway resistance as they do as if they had apnea. Today, you see, it's the apnea-hypopnea syndrome. And so, in that context, we're treating hypopneas as seriously as we're treating apneas. And upper airway resistance belongs there too. It's just, if you take the standard low enough, you start to wonder, well, doesn't everybody have this condition? If everybody had this condition, then insurance wouldn't pay. So some of this is political in definition. So early recognition and prevention are the key words. The symptoms of sleep-disordered breathing are indistinguishable without a polysomnographic study. Let's go. Symptoms common to both obstructive sleep apnea and sleep-disordered breathing. It's basically the same list you have that's in your chart. I'm not going to read it. Failure to treat sleep-disordered breathing in children puts them at risk for serious health problems later in life. These are the serious health problems that we see in our practice when a patient presents on a referral with sleep apnea. The evidence is indisputable that early diagnosis and treatment of sleep-disordered breathing in kids is mandated. Okay, now that you got the mandate, you have to know how to treat it. You know you need to do it. And then children, as we said, I think I said some of this, but children are not the same as adults. And so children manifest sleepiness differently. We talked about when your kid is at Disneyland or the zoo late on a Saturday or Sunday night, you say, okay, kids, it's time to go. And they go, yeah, we were tired anyway. No, not. They're going to act out and not want to go home. And so children act out their tiredness with inappropriate emotional behavior. This is what you hear from your teacher. Let the teacher write the note home and saying, your child is acting out, they're tired, as acting out with inappropriate emotional behavior. If the teacher would put tiredness in that sentence, then the problem would be easier to deal with. So, but the note will say, your child is acting out with inappropriate emotional behavior. When you see that or hear that, think tiredness. Their attention span is extremely short. They have delayed development of motor skills. This sounds like the note. I think they take this form and they write the stock letter home from schools. This is everything. Your child has delayed development of motor skills. And your child, as a result, has this low academic achievement. They're getting a poor report card because of acting out, because of this. And the cognitive development is very slow as well, Mrs. So-and-so. They have a diminished ability to develop and sustain an organized, future-oriented, and flexible approach to problem solving. We just define that as executive dysfunction. The very incidence of ADHD in children there is a very high incidence of ADHD in children with obstructive sleep breathing. We just described the sleep breathing kid with ADHD. Children who snore are more likely to have attention and hyperactivity problems. If these symptoms are untreated when noted, they are much likely to become worse 4 years later. They don't get better if you leave them alone. You cannot leave them alone. What are the cardiovascular? Let's look at the system by system. Kids, cardiovascular. Kids with sleep-disordered breathing are 3 times more likely to have hypertension. The elevation of blood pressure in kids is proportionate to the severity of the sleep breathing disorder. Sleep breathing in kids predicts cardiovascular risks later in life. C-reactive protein increases in kids with sleep-disordered breathing. And, as Lee knows, it's a sensitive marker for systemic inflammation. Mike knows that too. And inflammation contributes to endothelial dysfunction, vasoconstriction, and atherosclerosis. Atherosclerosis in children, how atrocious. And so, again, the growth that's occurring in dentistry is we have a new concern for oral and systemic health.
Alan, what percentage of pediatricians are familiar with this? I mean, do a lot of them know this? Not many know this?
You know, it's interesting because Gloria and I, we went on a rampage, and we must have done 10 lunch and learns. Seemed like we did 10. And they all pay lip service to knowing this, but you don't get the referrals. The answer is, I don't know any more than you do. It's a hell of a question. Let's ask them and not us, because they're so cordial, and they say, yes, we know, we're so happy you're here, we're so happy to see you. Oh, and now we know who to refer. And you walk out the door, and it's gone. And by the same token, where she should tell you, you go in there, and there's like 10 physicians' names on the door, and there's 3 eating lunch with you. And one is nursing the baby, the other is doing paperwork, the other was sick today, and one just doesn't give a damn to come in. So, I mean, that's the kind of thing you have. There's not this high level of interest. You know, we could tell you do lunch and learns, but it's like beating your head against the wall sometimes, and the referrals are, again, how many know it? They all say they know it, but they don't know it. That's really the truth. Okay, so look at what you have here. How atrocious is this? These are the kids. The only consequence that can happen from what these kids are going through is, whoa, wrong one, is hypoplastic midface. These kids are going to have small, underdeveloped maxilla. And so while the apnea is temporarily treating the condition, it's making the condition worse, period. And so, yeah, there's plenty of pictures like this, and there's even more. Look up CPAP in children on Google, Google Pictures, Google Illustrations, Google, okay, that's what Google Imaging, thank you. And that's where when they come from there, this is just 4 out of about 3.5 pages full. I just picked the prettiest kids, but the point is this is not a good solution. It's a horrible solution. We have better answers than this. This one here, look at this. They put the CPAP on the dolly, so the kid should feel comfortable wearing it. And then the other arm he gets his gorilla's pet. But the point is, look how young this kid is. What are the chances, this kid, if you treat him this way? And so Okay, we got to do better than this. We have better than this. That's what we're going to talk about. The consequence of CPAP use in young children is mid-face hypoplasia, smaller nose, smaller maxilla, more nasal resistance, less room for the tongue. Okay, that's mid-face hypoplasia. The maxilla doesn't develop here. The tongue has to fit. This should be out here. It's not there. Okay, so what do? Kids, you look at the kid's mouth and you see the tonsils and adenoids. And you take out the adenoids and the tonsils and you get a picture that looks like this. You go, wow, that hole is huge. 80% improvement is reported. Cure rate is defined, 80% defined as disappearance of signs and symptoms and normalization of respiratory measure. Oh, wait a minute, if this is such a good thing, how come it doesn't work 100%? 20% persistence of obstructive sleep apnea. But tonsillectomy and adenoidectomy, TNA, doesn't address accompanying symptoms. It doesn't address the allergies. It doesn't address the dysfunctional reflex patterns of swallowing. It doesn't address the mouth breathing, and it doesn't address the orofacial hypoplasia. This is the one. When that happens, send them for the therapy. Teach the kid to swallow. Teach the kid to breathe properly. This kid doesn't know. Kids don't come with instruction manuals. This kid doesn't know that he's supposed to use his nose now. He's never been using it. Habitually, he doesn't know what the hell his nose is for. So now, this kid's got to reorient this whole frame of reference. He's got to learn to stand up straight. He only knows how to walk around like this. So this is a lot of therapy. It's not just, it is myofunctional. They know all this. And again, ask the pediatrician, ask the myofunctional therapist the same question. What happens? Do the pediatricians know what they should know about myofunctional therapy? And the pediatrician will say, yes. And then the myofunctional therapist will say, if they're standing behind them, they'll go, no, they don't pay any attention. It's all about face time. It's all about chair time. These kids in a pediatrician's office, they're coming out the woodwork. They're standing in line in the hallway, and they got runny noses, and they get 5 minutes of face time, and they get a prescription for some antibiotics, and they're on their way because the system doesn't treat disease, and the system doesn't treat wellness. They don't address wellness. So, okay. Kid comes in and you see something that looks like this. Kid's got to breathe with that airway. Oh my goodness, this is the same kid. And so, look at the nose this kid's got to breathe out of. We got restricted nasopharynx, you got swollen adenoids, you got small airway. We got to deal with this. Okay. So, Carol Marcus, University of Pennsylvania, brilliant researcher. She says, inflamed, enlarged, infected tonsils and adenoids are not the cause of the obstructive sleep apnea. Wait a minute. How many pediatricians know this? Kids with obstructive sleep apnea at night do not obstruct during the day. Repeated studies have not been able to relate the size of the tonsils and the adenoids to the incidence of obstructive sleep apnea. All kids with enlarged tonsils and adenoids don't have obstructive sleep apnea. There are kids with very small tonsils and adenoids who have obstructive sleep apnea. And there are kids with obstructive sleep apnea whose obstructive sleep apnea persists after tonsillectomy and adenoidectomy. So what do we have here? 5 good reasons why the tonsils and adenoids are not the cause. They're just a coincidental incident factor. There is strong evidence to indicate that no one treatment modality gets 100% successful results. The gold standard, tonsillectomy and adenoidectomy, doesn't get 100% successful results. We're talking here about multidisciplinary. Involve your other professionals because you establish a viable referral network, you establish respect for yourself, and who do you involve in this? You involve the pediatrician, you involve the sleep specialist, you involve the allergist, the surgeon, the pediatric surgeon, the neurologist. There's pediatric neurology as a specialty. You involve the dentist, you involve the myofunctional therapist, and you involve the pulmonologist. This is a good, if you got those in your referral network, it's a good system. It's a good thing. Here's the story. By age 4, 60% of facial growth is complete. Age 4, 60% of facial growth is complete. By age 6, 80% of facial growth is complete. By age 11, 90% of facial growth is complete. When the second molars have erupted, the kid's done growing essentially. 90% of facial growth. So orthodontic treatment after age 12 virtually assures relapse. Look in the orthodontic literature. They get 2/3 relapse on all orthodontic cases. Wait a minute, how effective is this? 2/3 relapse. Early orthodontics, however, addresses breathing, swallowing, and posture problems, as well as making more beautiful faces. Kids with breathing problems can't wait until they're 12 years old to breathe properly. We look at all these comorbid symptoms. These kids are suffering in school. Their kids are suffering health-wise. These kids are getting obese. Kids are healthier, happier, and smarter and better behaved when they sleep well and breathe well. That slide doesn't even belong there. Everybody should know that. Orthodontics at an early age as possible takes advantage of growth, reaps huge psychological and physiologic gains for the child. How early do you start this? Here's my opinion. Everybody here at least had pediatric anatomy. So let me review it without asking questions. The deciduous molars look like this. They have roots that are so much wider at the apex of the root than they are at the crown. You virtually can never extract these in one piece, right? They come out and you're picking pieces out all morning long. This is not a simple extraction. Okay. What does this say to me? This says to me, you have huge anchorage. As soon as that deciduous molar's in, the anchorage is huge. Not even as soon. That's huge anchorage. And so I believe that at some point at about 3 years or 3.5 years of age, you have these teeth like this, and that's huge anchorage. That's when I'm looking to start, because I could use those teeth as anchorage to expand the palate. Okay, now, kids, let's think about this 6-year-old kid. All right, so there's a little bit of resorption starting on those teeth. They're still plenty big. But you can't use a 6-year molar. The 6-year molar that just came in the mouth looks like a coffee cup. It's hollow. It's got nothing but pulp in the middle. It doesn't have roots yet. Okay, we're not going to use that for anchorage. So we're going to wait now until that tooth has anchorage. And so when are we going to get that anchorage? Maybe 8. But at 8, now that 3-year molar is starting to, the deciduous molar is starting to lose a little. So between 3 and 8, this is a golden era, a golden age of opportunity for us. And I don't see people doing orthodontics at that age. You got a little bit of a weakness between 8 and 12 because you don't quite have the anchorage you want. But again, pediatric dentists are finding it. But the point is, I think you can start as early as 3.5. As soon as you got roots on that tooth, that's the time to start. And not only that, what a great opportunity. None of these sutures are wide open, they're soft as mush. They may not even have complete healing of the whole head. It's just, you're dealing in mush and you got good anchorage. Let's go for it. That's the time. Okay, we have a behavior problem. Delayed development of motor skills. This is what you ask about. This is not, rocket science to get this information.
Alan, you have failure to thrive, meaning underweight, essentially. No overweight mentioned there.
This is a kid I'm looking for because this is a kid that's easy to treat. The point is with these obese kids, they're much harder, and the problem is much more intense. It's hard to get with these kids. You don't just, when you do this, you don't get the, if you see these morbidly obese kids, they're murder. I'd rather, if I have to deal with them, I will, but they're much harder is the point. Yes, obesity is the other end of the spectrum, but when you see these kids, I see this because when I'm at the sleep center and they have these, 210-pound, 8-year-old kids coming in, they're so sick, and the problems are so huge. They're overwhelming in terms of the kids. They say, oh, this kid's going to be retarded, and this kid's going to be that, and slow, and the kid can't walk, and the kid can't breathe, and they can't breathe. They have so much weight, they just can't breathe. And so it's very hard. They have it, but I find that, you know, it's just, they're very difficult. That's the kid I would refer to somebody else if I could. So, clues in the dental history. Hypotrophic face and or jaws. Just look at them. Open bite, cross bite, overbite, overjet, and dysphagia. And a mandibular step plane of occlusion. You will see that in deciduous teeth. Okay, so we see this kid come in. That's what I'm talking about. This kid got retrognathia? Yes. Is this kid going to be a mouth breather? Yes. This kid got a head forward posture? Yes. Okay, let's look at all of these. This is exactly what I described in the previous slide. Open bite, cross bite, retrognathia. Every one of these kids. Deep overbite, step plane of occlusion. This kid here, I didn't go into enough detail, but this kid here, this is going to be step plane of occlusion. There's a dysphagia here. This kid has got the overbite because he's swallowing with the tongue in between the teeth. These are all breathing problems. All kids with malocclusions may not have obstructive sleep apnea, but you got to understand the breathing problem and the relationship between the two. And if you understand that, and you understand that you can improve the quality of life by treating these, and when you do treat them, you prevent obstructive sleep apnea later. So this is the thing. Palpable expansion creates more space in the mouth for the tongue. It facilitates positioning of the tongue anteriorly and in the roof of the mouth. Remember we were showing you those ICATs, and Gloria and I just say, there's nothing we could say or do to these people. We can't seem to get the tongue up there. Well, there's a reason. There's not enough room up there. If they can't do it, they can't keep it there. And so palpable expansion facilitates positioning of the tongue anteriorly and in the roof of the mouth. It widens the nasal passages and facilitates nasal breathing. It decreases nasal resistance. The roof of the mouth, after all, is the floor of the nose. Palpable expansion decreases nasal resistance, and it decreases collapsibility of the nasal passages. Kids whose airways do not collapse at night as a result of palpable expansion also enjoy improved breathing during the day. This is key. This is not just a nighttime condition. When we do these palpable expansions, it's not just at night, and then it collapses during the day. We improve their function during the day. When they're in school, they're going to feel better. When they're at school, they're going to be less sleepy and more energetic. Roof of the mouth. Roof of the mouth is the floor of the nose. There's the floor of the nose. So, here's the devices. You know, there's plenty of devices out there, and they got all kinds of bells and whistles, but basically, you want to go in two dimensions. You want to go side to side, or you want to go front to back. You want to go side to side, or you want to go front to back. So you got upper appliances that go front to back. You got lower appliances that go front to back. You got upper appliances that go side to side, and then you got, you know, lower appliances that go side to side. Okay, yes, it's harder to expand a mandible, but then again, when these kids, I think it's nobody's going to argue that when you treat the upper and make room, the lower plays catch up. The mandible always seems to play catch up. So the earlier the better, because the earlier you do it, the more time the mandible has to play catch up. I'm glad you're shaking your head, because I need that assurance. I say this stuff like, you know, some of this is ethological. Some of this is observation. And some of it people tell you who learn it by observation too. What I'm saying to you, there's not a hell of a lot of literature, is there, on this anywhere? And so, you know, I honestly, I did this stuff 25 years ago, and everybody convinced me I was such a heretic I was going to lose my license. So I stopped doing it. I moved downtown, I stopped seeing children, and now it's the fun of my practice. It's such a pleasure. But this is nothing new. These appliances have been around for 4 years. You can go to the oldest textbook in the ADA library, and the same gadgets are there. And I don't even know if they've improved them. So, okay, here's patient. Patient comes in. This is the example. They said this was failure to thrive. They said this kid had an AHI of 22. The kid had his adenoids out 3 times. He had his tonsils out. Adenoids, they scrape them. They don't remove them. And they just keep growing back. So the kid has difficulty with everything. The kid also, they said later, we look at the kid, they said later he has an unknown, or how do they call it, a syndrome of unknown, unidentified and unnamed syndrome. They felt he had a syndrome because they felt his ears were too low. So, okay, February 23rd, 2009, this is the before picture. Here's the after picture. We did palpable expansion on this kid. Can you see a little difference? Yes, you can see a little difference. Yes, he's wider here, isn't he? Obvious difference. Okay, let's look at what else happened. So this kid here had some sort of a defect, and so they went in and extracted this tooth. It's not like he was missing it. He saw a pediatric dentist, they took it out. But the point is, this is what he looked like before. A little bit of a deviated septum, and...
Alan?
Yes?
Was that rapid or relatively slow palatal expansion? Do you recall?
I'm going to tell well, let me go on here and then we'll discuss it because I got the answer for you. Okay, so then but this was the days in 2009 when we did this. I didn't have my own iCat. So we sent him out to the university, and again, this iCat, who was it, told me that there's a newer model now, even than mine a couple years ago. And so the newer model is what, an 8-second exposure, somebody said? Well, they can do 4s, but you don't get all the detail. But typically it's an 8, 4 with the, okay, he's got a 4-second exposure. We have a 4. Yeah, we can. The new model has a 4-second routine exposure. It's negligible, is what it is. And so this kid gets from this picture, they hate it. They take it's like something like 10% of his lifetime allowance of radiation from a hospital CT scan. But they felt it was legitimate that the kid get it, so they did it. And so the interesting thing about this is the radiologist wrote the report, and they looked at this report and saw absolutely nothing. And so they said that the kid has a little hyperextension of the neck and a little bit of change in a couple of these upper cervical vertebrae. And that's all they saw. And so when I look at this, what I'm seeing is, hey, is this not maybe a microglossia? And I'm seeing retrognathia, for sure. And so, interesting. But then, here's the story. He started out on February 23rd, and he was 37.5 millimeters. We gave the kid, the mother, the turning, the key, and the mother turned it, I think, every day. And at the end of the 2 months, they turned it every other day. The kid at the end of 2 months was 47.5. So in 2 months, 9 weeks it was, that's what the dates were. In 9 weeks, we got 1 centimeter. So they would say that this was semi-rapid. And so here's the interesting thing. Because how fast is fast? Well, I thought this was pretty fast. But it's not rapid by criteria. It's semi-rapid. And so you may comment. Do you have a microphone? This one here?
On the right, that patient has only 4 teeth, and on the left, 5 teeth, so the space is not, like we didn't create that space. The child had supernumerary fused something, and that had been extracted before we started. So this looks kind of funny, but that's not, we didn't do that.
Okay, we didn't do that. We did this to him, and they saw the face. There it is again. So we're looking at roughly 9 weeks. In the 9 weeks, that's the result. Okay, and so when you look at the PD, this is the one I'm telling somebody. So the results are so astonishing. So wait, I'll finish here. Here's the 2 reports. The final report is there was considerable improvement in the frequency of occlusive and partially occlusive respiratory events. They're not talking apnea. They're talking occlusive respiratory events. and the oxygen saturation following insertion of the trainer, the EtCO2 baseline increased, suggesting respiratory compensation for previously retained CO2. Okay, and so the point here is that this kid, the pediatrician came in the office, and he says, "Oh, we negotiated the final sleep study. The final sleep study was 2 hours, 4 hours, nothing. 4 hours with maxillary expansion, and 4 hours trainer. We put a Myofunctional Research Corporation trainer. I'll show you that. Let's see if I got that next. All right. I put a trainer in the kid's mouth. So half the night he slept with nothing, and half the night he slept with the trainer. And so he did okay. Remember, this is the kid, he had an AHI of like 22. And so he did okay. He was down to about 11, and they put the trainer in, and just like that, within seconds, the kid's carbon dioxide got right, the oxygen got right, and he was breathing. And so then they wrote this report, but more importantly, they were astonished. The pediatrician saw the sleep study, and he comes in the office, "What did you do? I need to know what you did." So I showed him the trainer. Anybody know what a trainer? I'll get to it. Okay, let's skip ahead here. After the CTs, the palate did not split. That's the interesting thing. You didn't split the palate. There's the x-ray after. Okay? Point is, yep, over there it is. The palate didn't split. How cool is that? That's the kind of growth. Huh? The bone grew. Look at how fast the bone grows in these kids. Now look at how benign that procedure is. We did. Used to be, you know, you're old enough, Jack. They used to take, you split the palate. You don't split the palate. It grows that fast. They just didn't have the x-ray equipment. They don't know what we're doing. Now we know what we're doing. We're not splitting the palate. And it's not so rapid. If it were not physiologic, you could split the palate. This is physiologic. The bone grew that fast. 9 weeks, 1 centimeter. My goodness, that's huge. That's huge. You show this case to the pediatric dentist, they go, "No, it's not physiologic. No, you did something wrong." No, this is the right way to do it. Okay, here's the interesting thing. So here's the after x-ray, okay? Here's the one looking, I'll show you the palate didn't split. Here's the other one. How interesting is this? Look at the occlusive adenoids grew back. In 9 weeks, you saw the earlier x-ray. There wasn't a clear airway. Look how fast the adenoids grew back. Boom. And guess what? In this picture here, the kid's breathing. So it's interesting. We expanded the palate. We decreased nasal resistance. Remember, that's a two-dimensional picture. The adenoids are sitting up on the sides. He's still got the middle of his airway because I made the middle of the airway for this kid. There's the adenoids again. And there's the myofunctional research trainer. Okay? They're on. You can go to myoresearch.com. These things are cheap. They're great. Various things you can do. I guess you can put a strap in there, or tie a knot and a rope in there, so they, I don't know, so they can tie them to the kids' pajamas and they won't fall on the floor. And actually, they make it now. This is getting so popular to do this. They actually make a regular and a wide, because after you expand the palate, it's wide. Now here's the other thing. So this kid did get a little teeny bit of relapse, even with this in. So what I'm doing now is I put the trainer in before I take the expander out. And all I do is I take a scissors. This is so easy to cut. It's like butter. You cut this out here, and let it sit in there with the palatal expander in there, so you don't get any relapse. You could even start, used to be where you'd wait until you finish the expansion. You don't have to wait to finish the expansion either. It's not logical. Cut this out, put the trainer in the day you start, and the kid's doing all the breathing. Because this kid on the sleep study didn't start to breathe until you put the trainer in. Yeah, we got some improvement with the palatal expansion. The palatal expansion plus the trainer, man, this kid's breathing. Why did I have to wait 9 weeks? Because I didn't know what I was doing. Now, You learn. You learn every time you do a case. So now they make these in wide and regular. And if in any case, cut this out, and you could leave the expander in there. So, okay, you don't want to leave the expander in because you want the tongue in the right place, but then there is a lull between the time they get to the myofunctional therapist, and during that time you could leave it in. It's just a little extra flexibility. You're not going to leave that, expander in for a year. You're not even going to leave it in there 3 months. But that extra 8 weeks, you might get a little less relapse while the kid's in transit from trainer to myofunctional therapist. And so you get lots of possibilities. This is really easy to work with. It's a pleasure. There it shows you could put this in the pajama button, and you have a lot of flexibility. I would rather not use this if I have a choice. There's no way a kid's going to ever swallow this thing. There's the wide. And then they make, this is T4K, this is called infant. They make a T4K wide. They got all kinds of sizes. They're ready to accommodate you. And if they don't quite, you cut these things. Okay, so here's the tool. Metabite records body position, chest effort, abdominal effort, obstructive sleep apneas, central apneas, you know the litany. Okay, there it is. My point, my take-home message. In Chicago, it was taking 6 to 8 months to get a kid into the pediatric sleep center. They're so booked. A pediatric sleep center is different. They have to have kids' beds. They have to have mother beds. The mother has to be in the room with the kid this age. And then they have to make it look like a kid's room. And then they have to have all the gizmos and gadgets. Then they have to have end-tidal CO2. It's a much more expensive facility. They have fewer of them. And so it's a 6 to 8 month waiting list. Here's the story. You get the pediatric, question?
They outgrow it.
What?
And then they outgrow.
Maybe. Again, if the kid's sick, get him in. So here's the formula. You put the pediatric belts. These were the old, what do they call it, the rip belts, Rick? Now you don't have to get the rip belts. We used the rip belts, so we just cut them and made them smaller. Now they have pediatric belts for the plethysmographic belts. And so we put them on, you put this on a kid, the kid goes home, goes to sleep, gets back the next day. That kid's got apnea, they get him in like that. They get him in like, if you remember now, with adult, they consider it not even worth treating if it's under 10. With the kid, 1. AHI of 1 and they're ready to treat. You do the study here, the kid comes back 3, 4, 5, 10. They get him in like that because they know they've got it. And we'll put you on the cancellation list. 3 nights later you're called. What do they do with those cancellation lists if you're not on? I mean, it's like interesting. And then you have a much higher regard for they do for you because you know what you're doing. Where the hell is you? What did you do? That's all you did, and all of a sudden you're in their ballpark. It's not the same kind of territorial warfare with the pediatric sleep labs. And so, hey, they even have a pediatric finger probe. They got it. It's easy. This is good stuff. And so that's what we have. So parents come in, same question. Do you snore? No, but you should hear my kid. Your kid snores? Does your kid wet the bed? Oh, how fast can you get this kid in for a test? Here, we'll show you. We'll give you the thing to take home. We just have to have it back the next day. And so we're testing kids, and they value. Again, in my office in this building, they don't like to bring the kid in, so we don't have a pediatric practice. So maybe we'll let the parent take it home. They know we show them how to fit it, or they bring the kid in to fit. But boy, it's a really appreciated service. Nobody's doing this. Nobody has this kind of equipment. And so it's a pleasure. And it's even easy to, I don't know.
Alan?
Yes.
If you have a kid that's apneic, you send it to the sleep study. Do they try to keep the kid and put him on a CPAP, or will they let it come back?
No.
And treat it ourselves?
You know what? You see those kids on CPAP. You know that the FDA, isn't this right? The FDA, it's not approved for kids under 7. It's contraindicated according to them. Oh yeah, that's right. What do they do with these kids? So they use it. But the point is it's contraindicated. It's not right. But what does this pediatric sleep lab do? Yes. But again, when you refer them, They're way more with it with you. And again, we're dealing with technical issues here. So you expand the palate, and 8 weeks later, you get a centimeter. Wait a minute. It may be 8 to 10 weeks before that kid got in the sleep lab. If you don't do anything, you could finish treating that kid. Did I do anything wrong by treating that kid? I mean, you know, everybody's worried about getting sued, but it's also more concern is how can you help rather than how can you avoid being sued. And so, hey, at our age, sue me, I'm out of there. That's all. I'll run to a foreign country, a banana republic. Kid on here. So here, this is the same kid. And so halfway in between the study, we did it. So we did a metabite study on the kid with the palpable expansion. And as you can see, he didn't keep his finger probe on too good. No. Yes, that's right. Okay. The teeth and dental alveoli lie in a position of balance between the cheeks, lips, and tongues. Ideally, the tongue is in contact with the roof of the mouth at rest during swallowing and nasal breathing. Interventions that disrupt nasal breathing cause opening of the lips, low tongue position, head forward posture, and malocclusions. We've been over that with adults. Same thing in kids. But the kids' teeth are forming, so they form ugly and malform. You saw the pictures of the dentex, the dental forms, and you know that's what happens. Okay, breathing. Primal function necessary for life. Rick told you, you could go for days without food. You can go for hours or days without water. You cannot go for more than seconds without air. The respiratory central pathway maintains the patent airway and dominates reflex control of the oral pharynx. The need to breathe supersedes all other reflexes. Human beings are obligate nasal breathers. The mouth is merely a backup breathing organ. The nose is ideal for warming, filtration, and humidification. We did a whole lesson on noses yesterday. You know the difference? Anybody remember the difference between leptorhine and platorhine? Yes. Okay, with nasal obstruction, the lips must part to allow air to enter the mouth. The tongue must lower itself to allow air in the pharynx. The hyoid bone lowers. The mandible becomes retrognathic. The airway narrows. The head assumes a more forward posture on the spinal column. Okay, sniff test. Kids have compensatory reflexes. Protruding the tongue affects oropharyngeal dilation, decreases nasal airway resistance. Retruding the tongue increases oropharyngeal resistance. Thumb sucking versus thumb propping, we talked about this yesterday. Functional adaptations of mouth breathers, we talked about this, and this. You've seen these lists, they're in your notes. A functional characteristic of mouth breathers, forward head posture. The result in long face, short face. We went over this yesterday. You saw this picture, and this picture. Sorry to do this, but when you go over your notes, you'll want the cohesiveness. Okay, let's go on here. Reflexes from the oropharyngeal area protect the anterior portal of the gastrointestinal tract, transport of food and liquids, airway for gaseous exchange. We need to protect the lungs from aspiration of food and liquid. Complex interrelationship. The swallow is the most complex reflex activity in the human nervous system. The teeth touch in a position of maximum occlusion in an ideal swallow. The lips are sealed. The tongue propulses the bolus of food distally against the palate. The head is braced on the spinal column, and the head does not move. So when you see a dog swallow and you look at pee-pee, the head shouldn't move. We have to brace the head on the spinal column. Okay. Swallow. Kids have compensatory reflexes. In addition to mouth breathing, they respond to obstructed nasal breathing. All right, look at this one. Kid, mouth breather. Lips apart at rest, chronic dry lips, chapped lips. Look at the smile. This kid is a mouth breather. Look at the malocclusion. It's evident on the smile. Look at the swallow. Look at this kid swallow. Look at the strain in the facial muscles to attain lip closure. Look at the lips pushing in. This is not only a dysphagia, but it's dysfunctional. Everything. Okay, look at the picture of the lips, the teeth pushed in. Look at the picture of the tongue pushing out. Look at this kid, natural rest position. Does this look okay? Look at the kid swallow. Look at the strained posture of the lips when this kid swallows. Look at the tongue thrust on this same kid. Okay, here's the kid. So what do we do for this kid? Well, you could do myofunctional therapy. In this case, they decided, these aren't my pictures, but these are from myofunctional research. They decided to put a trainer in the mouth. This is the kid with the blue trainer in the mouth. This is what they look like. And then the jaw is positioned correctly and the tongue is corrected. That little button on top is the tongue, toy. Okay, here's another kid. Look at this kid in rest position. Look at this strain in this kid's lips trying to swallow. Look at the malocclusion, the results. So this kid here had some sort of a defect, and so they went in and extracted this tooth. It's not like he was missing it. He saw a pediatric dentist, they took it out. But the point is, this is what he looked like before. A little bit of a deviated septum, and...
Alan,
Yes?
was that rapid or relatively slow palatal expansion? Do you recall?
I'm going to tell well, let me go on here and then we'll discuss it because I got the answer for you. Okay, so then but this was the days in 2009 when we did this. I didn't have my own iCat. So we sent them out to the university, and again, this iCat, who was it, told me that there's a newer model now, even than mine a couple years ago. And so the newer model is what, an 8-second exposure, somebody said? 4, well, they can do 4s, but you don't get all the detail. But typically it's an 8, 4 with the, okay, he's got a 4-second exposure. We have a 4. Yeah, we can.
The new model has a
4-second routine exposure. It's negligible, is what it is. And so this kid gets from this picture, they hate it. They take it's like something like 10% of his lifetime allowance of radiation from a hospital CT scan. But they felt it was legitimate that the kid get it, so they did it. And so the interesting thing about this is the radiologist wrote the report, and they looked at this report and saw absolutely nothing. And so they said that the kid has a little hyperextension of the